Thank you so much for the panel and sages. I think to invite surgeons and all the presentations thus far have been excellent. I've been very impressed. I think we have a very bright future in front of us. But surgeons are positioned at exposed to the gap of what's necessary for surgery, and I think we're ideal positioned to kind of recognize that unmet need. So I think these forums are very paramount to the future of surgery, and I'm glad that surgeons are a part of it. I think I'm presenting a topic that we all can get behind, leak resolution and treatment. Was told once the only surgeon not to have a leak is a surgeon that does not operate. And I learned the hard way the most difficult leak to manage is that of created by your own hands. I think leaks are more complex than staple misfire, misfunction. I think we're dealing with interluminal pressure and capillary blood flow. It's not just blood supply. But in recognition of the problem, the treatment options suffice, but leave for a better tomorrow. You know, the competition right now in stents and interluminal expandable nitinol stents, they do suffice. However, they have their complications regarding mobility and erosions. With that, I think there is a better way, and therefore I'm presenting the solution of enteric anastomotic leaks, the seal tube. I think it's a catchy name. Came up with that my own. By the way, I'm a single solo private bariatric surgeon in South Texas, and the company just consists of myself. Anyway, this tube is as simple as a nasogastric tube. I'll give it to the plano to play with. It cost me $10,000 and damn near a divorce, so don't break the tube. The first aspect is treatment resolution of an active leak, and if you think of an esophagectomy or a gastric pull-through, or in the case of a bariatric surgery, specifically a sleeve gastrectomy, which is what birthed this product in my mind, it's got to be something that resolves the problem regarding diversion of the spillage. It is a stent, therefore it does have a lumen involved with it. It's capable of exerting negative pressure on the outside diameter of that stent to give negative pressure to the site of injury, and a tube that courses through that for distal feeding tubes, and of course limited PO intake through the mouth. So in my mind, this is going to be an easier, quicker resolution of everything in reach of an endoscope, which is both upper and lower. Regarding the negative pressure, you have an increased vascularity. Therefore, I think you can immediately start healing, just like in the vac dressings of the external. It can increase the blood flow of the anastomosis and reduce the interluminal pressure. But it's something that can fit all anatomical configurations, including the loop DS, looped gastric bypass, sleeve gastrectomy, gastric pull-through procedures, including all the variety of colorectal. If you look at the leaks, the most difficult ones are at the point of sphincter, right below the lower esophageal sphincter and right above the anus. Those are the high-pressure regions and the really symptomatic leaks. So in my mind, that's the first utility of this device, is quick, easy, and reliable access. Much like passing a nasogastric tube, you inflate it. It's going to have barium paintings on it, so in fluoroscopy, you can put it fluoroscopically. You can place it blindly at the time of the surgery or endoscopically, so it's multimodal. The second, I think, is the most powerful bang for the buck regarding anastomotic prevention, or protection, that is. If you look at the colostomies performed as a bariatric surgeon, there's no real out for diversion. If I do a spit fistula, I'll probably get no more patients. The colorectal surgeons have that protection, but it's something that's very unsavory to the patients and the surgeons alike. So therefore, in a prevention aspect or utility, you're decreasing the ostomy formation and decreasing the potential risks of reoperation, therefore incisional or ventral hernias as well. And of note, 53% of most of the bariatric litigation comes from leaks. So I think resolving that, or at least reducing that, is one less headache for a surgeon to deal with. And then lastly, regarding the future, you know, I've been in private practice for 10 years now, and I think the evolution of surgery is best described as you start with a 10 blade, it went to 11 blade, and now you're doing it with an endoscope. And I think And in the very near future, we're going to be doing a lot more endoscopic surgery, and you see that in certain practices. But they will have their limitation regarding submucosal and mucosal resections, regarding strictures and leaks as well. Current technologies, this technological platform could give rise to enteric split thickness skin graft, as well as mucosal transplants. And I think that's something that could realize from a platform that could fix that biologic tissue against the abdominal wall with negative pressure. And in summary, hopefully I'm under my 5 minutes or 4 minutes, I think this is a technological advancement that could decrease the heart rate, increase the blood pressure, and even return appetite. And that's only considering the surgeon, let alone what it can do for the patient. I think it's necessary technology, and I definitely look forward to the panel discussion. Thank you so much.